About 16 there. Sit back for me.
That's not bad.
Not bad. I would love to check it one day and
That would be 12.
be 8.
Oh, 8. Yeah, right. Maybe when she was 84, not 94. Do you consider like the thickness of the cornea?
Always.
Yeah?
Yeah. Not that I change my measurements with that, because measuring pressure is already an inexact science, and some people will kind of alter their pressure readings and say, okay, if you're thick, I'm going to deduct a couple points.
Right.
If you're thin, I'm going to add some points.
Right.
But those are equations upon guesses, you know, I mean, so for me, I just kind of take into consideration what the corneal thickness is.
Yeah.
And what that means for the potential pressures that I'm reading.
Gotcha.
And basically, I get more concerned when you have thin corneas rather than thick. And yours are running thick.
Because they're new.
Right, and you know, with the history there, it makes sense.
Mm.
So we're running about 12 last time, 16 this time.
Getting worse.
Just seeing your normal variability, you know, the more we see you back, the more we get a real sense of where your pressures are.
Yeah, because if you took it 10 o'clock this morning, it might have been different, or tomorrow, right? I mean, it's
Correct.
like blood pressure, isn't it? Similar to that?
Yeah, there's a fluctuation. Typically, the pressures tend to peak in the early morning hours and then come down
Okay.
through the day, but that could be reversed for some people, and minute to minute it can change, you know.
She's having a hard time seeing more in the last month. Well, ever since your operation, really. But I think it's more retina involved, really, than her glaucoma.
It could be both. And
Yeah.
honestly, it could be both.
Yeah.
The severity of your glaucoma, usually we say that glaucoma affects your peripheral vision before your central vision, right?
Yeah.
But the severity of your glaucoma, the central vision certainly affected. You know, and the part of the motivation to do the surgery was the concern that you felt like your vision was getting worse, you know.
Yeah.
And so again, I would love your pressures to be, all joking aside, 8 to 10, because then I would feel like, okay, we've done everything we possibly can for the glaucoma. But to do that, to try to achieve that, would mean subjecting you to yet another surgery. You know, is that in your best interest here? You know, because with each surgery comes the risk of problems.
Well, I'm 94 and a half, so pretty soon I'll be bye-bye.
She says she'll be feathers. I said, well, in your casket, do you want me to put a couple feathers there just to, you know, to make you happy? I'm sorry, we tease each other like that all the time.
If I did anything, it would not be any further tube shunt surgery or anything like that. It would be the laser stuff to turn the faucet down. That would be our next step if we so desire.
Yeah.
So that shunt really isn't, it's helping.
It's helping, but it's not helping as much as I would have liked. And
Yeah.
again, I was not confident in putting in a really aggressive tube shunt where we run the higher risk of low pressure problems, which can expedite vision loss significantly. So we put in another valve device, and that can continue to change over the next months or so, but there's no way that I was putting in a big aggressive tube shunt where we drop to a pressure of 2 and then you develop bleeding in the back of the eye and stuff from that. So at this juncture, I think, you know, we stay the course with the medicines you've got, but stay in close touch with each other, maybe 3 months, check on the pressures again.
Sounds good.
Okay.
I can't even see you.
Mom, if you just looked for your left eye, you couldn't see him?
No.
Because she keeps telling me, I can't see very well out of my right eye. I said, I know, because you're blind. You know, she keeps trying to see out of both eyes. She can't.
And then put a bright light in front of you like I just did, and the little bit of vision that you have really gets knocked down quickly.
They can't do anything for retinas, right? I mean,
No, at this point, there's a brand new treatment that just got FDA approved 2 weeks ago for geographic atrophy associated with dry macular degeneration, but not the other changes. Like right now, you don't have significant geographic atrophy. So I don't know the details of that medication, but I don't know that you would qualify for that or that it would help you.
Is this where I dropped this?
I got you. And then on the same token, they don't have anything to repair a nerve, you know, and that's really where a lot of the problem is with the glaucoma. The nerve conducting the signal from the eye to the brain is damaged, and the signal just doesn't get back there as well.
and we don't even know what really causes glaucoma. It just appears.
We don't. There's going to be multiple diseases that produce the same result, but we don't know, you know.
You know, about 2 years ago, I think it's about 2 years ago, a lady doctor told me that she could do this eye.
Laser,
And she said, but it may ruin your
cornea.
cornea. And I said, no, maybe I should have done that.
No, it's hard to look back on that, you know, and know what the right choice is. Your eyes are just so complex, and you've been through so much, you know, and I mean, look at the fight that you've put up with the left eye, even in recent times, right? We've done some laser, we've done another tube shunt. This shows the limitations that we have currently with glaucoma management, where we're just treating a risk factor, we're not even treating the disease, you know? So, now, if you said, go ahead, do that laser again, you know, to turn the faucet down, I think that would be a reasonable thing to do. Not that it would restore vision, but it'd be, again, another potential of getting the pressures down. So that's the option I leave on the table.
Yeah.
You know, if we desire to pursue that, to try to push the pressures lower, to try and slow the pace of things down, you know, but, you know, again, it's tough because each thing you do can also compromise the nerve just by the stress of going through another surgery.
Yeah.
And being another year older takes away the same nerve fibers that glaucoma takes away, you know. But technically, are there things that we could do to lower pressure? There are. You know, it's just, will that make a clinical difference in the course of things here?
Yeah, it's tough.
So.
Like Dr. Zalta said when he put that shunt in, well, you'll be fine now till you won't have to worry about it. I told my mother goes, well, yeah, I didn't think I'd live to be 94. And now Dr. Goulet's going, hey, lady, give me a break.
Well, I'm certainly not throwing the towel in. I don't want you to think that.
Yeah.
But I want you to know my thought process and kind of going through all the options here, you know. And I'll leave that on the table as a possibility. The laser procedure, again, where we're trying to laser the fluid producing part of the eye.
Well, if we see in 3 months, what if her pressure is like 14, you know? I mean.
Correct.
Yeah.
Correct.
Could be.
I mean, and again, you know, it's like, you can keep chasing these pressures sometimes and dig yourself a bigger hole, and it's just a tough situation.
Well, when she watches TV at night, she can see the TV and all that stuff. That's, you know, I'm like, hey, let's just live one day at a time and see what happens here.
We'll keep up with the medicines, and like I said, 3 months, let's check on things, and if something changes from your mindset or anybody's, just call. Let me know.
Right.
Okay.